Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. On the podcast today, I'm joined by our deputy editor Nick Bostock to talk about how adding GPs to the Additional Roles Reimbursement Scheme, or the ARRS, has impacted on the workforce in different parts of the country. We'll also be looking at what the government has to say and asking whether it's painting an accurate picture of the current state of the GP workforce in England. And we'll be discussing what the BMA wants the government to do to avert a jobs crisis for newly qualified GPs this summer, as well as a series of red lines that it has asked the government to deliver on to avoid further industrial dispute by the profession. Our good news story this week is about some more data from an innovative fruit and veg prescription project that's running in East London. Before we start, just a quick message from our colleagues on MIMS Learning. In-person learning is a vital part of keeping up to date, enabling GPs and other health professionals to learn with colleagues, ask questions of expert speakers and benefit from networking. MIMS Learning's event page gives you details of all the general practice focused learning events, which will provide you with practical take-home points for your practice, along with CPD certification. Visit mimslearning.co.uk/pages/events to find out more. Hi Nick, so maybe let's start off with the Additional Roles Reimbursement Scheme. So the ARRS is where primary care networks or PCNs receive funding based on their weighted patient population to recruit extra staff to work in their member practices. Up until last year, it had covered almost any other role apart from a GP. But in October last year, GPs were added to the scheme, weren't they? We've talked about this on the podcast quite a lot before, but just remind us why all of that happened.
Yeah, so less than a month after the general election last July, Wes Streeting, the Health and Social Care Secretary, announced that the government was rolling out this ARRS scheme for GPs. As you said, previously GPs weren't part of the ARRS at all. It was a scheme that ring-fenced well over £1 billion a year in general practice funding for recruitment of staff other than GPs, staff from a list including physios, pharmacists, social prescribers, care coordinators, podiatrists, occupational therapists, like you said, almost any other role you can conceive of in a general practice multidisciplinary team apart from GPs themselves. And by the time of the general election, we'd been reporting for a long while on the fact that thousands of qualified GPs were struggling to find work. The BMA called it a toxic paradox. And it was just an outlandish, ridiculous situation for large numbers of available UK-trained GPs to be out of work at a time when general practice was under unprecedented pressure. And all that money focused on the ARRS over the previous sort of 5 years or so had brought around 30,000 extra staff into general practice. And in many cases, GPs would say that those staff have had a really positive impact. But the problem is core funding didn't rise enough over the same period to give practices the money to recruit GPs as those ARRS staff came in. So we had a GP workforce in decline, managing an increasingly complex patient population, overseeing this expanded non-GP workforce, and under massive pressure. Wes Streeting himself called it absurd that GPs were out of work, and his solution was ARRS jobs for GPs. The government found £82 million down the back of a Department of Health sofa. The money came from its existing budget. And it said this would be bolted onto the ARRS to create 1,000 GP jobs between October 2024 and March 2025. So that's the second half of the last financial year. The jobs were not for all GPs. They were only open to GPs who'd qualified in the past 2 years and had not previously held a substantive post in general practice, so for newly qualified GPs only. It was described as an emergency solution at the time, but it's since been rolled over into the contract package for the current financial year, and it's alongside a much more significant change. That initial funding for ARRS GP jobs was separate from the wider scheme, but from April this year, the government rolled GP ARRS money in with the rest of the scheme and changed the rules so that PCNs now have much more flexibility about how they can spend it. So the ARRS is worth around £1.7 billion nationally in 2025-26. And PCNs can now spend up to 100% of their share of the funding on newly qualified GPs if that's what they want to do. There are now no limits on the proportion of ARRS money that PCNs have to spend on any particular group of eligible staff, including GPs.
How has recruitment under the scheme gone? How many GPs do we know are employed via the ARRS now?
So this is quite an interesting one to dig into. The government published some new statistics on numbers of ARRS GPs just recently, and it now says over 2,000 extra GPs have been brought into the workforce because of the scheme. It's fair to say there are a good few caveats that mean we can't quite take that figure at face value. The figure the government's referring to when it makes that claim of more than 2,000 extra GPs from these new statistics, that latest set of data show that 2,068 GPs have been recruited through the ARRS in total. But this is a headcount figure, and it doesn't tell you whether these GPs have been hired to work full-time, less than full-time, or whether they're even working for just a session a week. And as it turns out, that's not the only reason this figure's dubious. When you read the notes on the data about ARRS GP numbers, it says this: headcount figures calculated by counting the number of unique GPs for whom at least one claim has been made over the whole period from the 1st of October 2024. So what that means is that the headcount total isn't current. It would include a GP who took up a post for a month last October and has since quit. So it's a pretty meaningless number, basically. What's a bit more meaningful is looking at the full-time equivalent numbers reported through the scheme. The problem with those is that it takes a few months for claims to ARRS staff from PCNs to be processed and to filter through into the workforce figures. So although technically we have ARRS GP numbers up to June this year, there's no point really looking at anything beyond about March, because beyond that, the figures just aren't complete. So bearing all that in mind, the latest data show that by the end of March this year, so the end of the initial 6-month phase of recruiting GPs through the ARRS, there were nearly 1,150 full-time equivalent ARRS GPs in post. It seems likely, too, that that figure may well have risen a bit since then, so there could be north of 1,200 ARRS GPs by now. So in fact, it's not insubstantial, and it's actually beyond the government's promise to bring in an extra 1,000 GPs. But the claim that the ARRS has brought in more than 2,000 extra GPs is at best misleading, and we're going to come on to this a bit more later, but it's also really not clear what impact these new jobs have had on the workforce overall.
You recently did an analysis of the figures last month, not this latest data, it was from the set before, and it found quite a worrying trend that suggests that maybe the ARRS is exacerbating GP workforce inequality. What did you actually find?
We know that across England as a whole, there are something like 2,260 patients for each full-time equivalent GP. But patients per GP vary a lot between ICB areas. So in areas we often refer to as the most underdoctored, there are as many as 2,900 patients per GP, and in the least underdoctored ICBs, it's around 1,850 patients per GP. So no ICB area has what the BMA would consider a safe patient-to-GP ratio. The BMA's talked about the safe limit being 1,800 patients per GP. It actually wants to get that down to 1,000 patients per GP by 2040. Actually, it doesn't want to get the safe limit down to that. It wants to actually bring the number of patients per GP down to that level by 2040. But some areas need GPs much more desperately than others. So I did a bit of work to try and find out whether ARRS GPs were going where they're most needed and whether the scheme looked like it might reduce that workforce inequality in any way. I looked at how many patients per GP there are in each PCN, and actually the variation is much bigger at PCN level than it is at ICB level. And then I compared that with how many full-time equivalent ARRS GPs each PCN hired by the end of March this year. What I found was that in the 50 PCNs with the lowest numbers of patients per GP, so the least underdoctored ones, the average number of ARRS GPs hired was 25% higher than in the most underdoctored 50 PCNs. The 50 most underdoctored PCNs recruited just under 1.4 full-time equivalent ARRS GPs per 100,000 patients on average in the 6 months from October 2024 to March 2025. And in the 50 least under-doctored PCNs, it was just over 1.7 full-time equivalent GPs per 100,000 patients. So, like I said, there's a 25% difference. And basically, it looks like adding GPs to the ARRS has actually widened inequality across the country in terms of the GP workforce, which maybe shows that although this scheme has had an impact, it has brought more GPs in, it needs work. It was a bit of a blunt instrument. The RCGP said it was concerning that it looks like ARS jobs haven't been funneling GPs to the places where they're needed most, basically.
We also know that some PCNs haven't made use of their ARRS funding to recruit GPs at all, have they?
It looks like about a quarter of PCNs overall haven't yet claimed for a single ARS GP. As you'd expect from the figures we've already talked through, underdoctored PCNs are more likely not to have brought in any ARS GPs. An analysis we did on that showed that nearly half of the 50 most underdoctored PCN areas haven't recruited a single ARS GP, whereas in the least underdoctored areas, it was only about 1 in 3. One point I think it's probably worth mentioning here is the fact that many PCNs haven't yet brought in an ARS GP, but at the same time, a fairly substantial number of GPs have been hired overall through the scheme. What that points to is that PCNs that have chosen to recruit through the scheme are topping up the funding available with their own resources in many cases.
Yeah, I was just thinking about that actually when you were talking through some of those differences, because at the start of all of this, there was an issue around the fact that the salaries that were reimbursed were very low for GPs. So if PCNs were going to recruit a GP via the scheme in that second half of 2024-25, they were probably going to have to do quite a bit of topping up. I mean, those salaries went up in April this year to the BMA recommended salary. So the maximum salary increased from £73,113 to £82,418. So that's what PCNs can get reimbursed now. So that's quite a big increase. And, you know, you were talking there about those underdoctored areas. They're often in deprived areas. And we know that funding is a real challenge for practices in deprived areas. Those practices, those PCNs might not have had the extra money that they needed to top up those salaries. The other big thing is that it will obviously depend on whether those PCNs have any available ARRS budget left to fund the GP roles. We've also talked on the podcast before about whether or not some of these ARRS GP jobs are actually attractive enough. And I suppose it really depends on how PCNs organise the roles, doesn't it? We talked about one GP we spoke to who basically had been working in a same-day hub across 3 practices and had very little supervision and didn't necessarily feel part of a practice team. But that's one example. You know, that person had moved on to an ARRS job, embedded in a practice somewhere else and was fine. You know, you touched on the fact that big change is that there's no separate pot of money for recruiting GPs now. It's all part of one fund. So with the salary increase and that change, we may start to see more PCNs take on GPs as other staff leave and ARRS budget is freed up. But obviously, the big thing to remember about all of this is that these posts are only available to GPs in the first 2 years of their career who've not had a substantive role in a practice before. So the scheme doesn't really do anything to help other GPs who are struggling to find work, does it? So the other aspect in all of this is what has the ARRS done to the overall GP workforce? How has it impacted on the workforce? Can we tell that from all of these facts and figures that we've got?
It really isn't clear exactly what the impact's been. As I mentioned earlier, the government talks about more than 2,000 extra GPs having been brought into the general practice workforce through the ARRS. And it's taken to repeating whatever the running headcount total is in virtually every statement it makes about its efforts to improve the NHS, which, you know, given previous governments promised thousands more GPs and completely failed to deliver on that, is perhaps not that surprising. We've discussed already why the more than 2,000 figure is misleading or potentially meaningless, but it's even more difficult to understand in the context of the overall GP workforce. It struck me recently that on the same day that the government was claiming this big rise in GP numbers, the RCGP put a statement out that referenced what are meant to be the overall GP workforce numbers that the government publishes. And those figures tell a completely different story. So according to those overall figures, the full-time equivalent GP workforce in England has risen by about 650 over the past year. We know from the ARRS figures too that there may be some overlap between GPs shown in the overall figures and in the ARRS numbers, but it's really not clear what the actual overall picture is. I asked the government to clarify, and they said it's not possible at the moment to combine the ARRS and the overall workforce numbers that come from GP practice IT systems. So basically, next time you hear the government say that there are more than 2,000 extra GPs, the truth is it has no idea how many there are. There are almost certainly more GPs, but it's nothing like as many as that. Wes Streeting likes to say that GP finances are opaque and murky, but they're probably not as opaque as the numbers the government trots out about the GP workforce, it turns out.
Obviously, one thing we need to bear in mind with all of this is that there are thousands of new GPs qualifying as we speak. August is a big time for new people starting GP training and registrars qualifying. The BMA warned earlier this year that up to 1,000 newly qualified GPs could be jobless when they qualified this summer. What do we know about all of that?
It's a really big concern. There are already thousands of GPs out of work or without enough work. And a cohort of registrars is due to complete their GP training around now, as you said. So whether they'll be able to find work is a really worrying question. We mentioned earlier that ARRS funding is now a lot more flexible. So potentially PCNs could start to divert more of their share of ARRS money to hiring GPs. And anecdotally, we hear that some are doing that. So these newly qualified GPs coming through now are exactly the cohort that would be eligible. But in general, where PCNs have used their full ARRS budgets to bring in staff over the past few years, and those staff are now integrated into their practice teams, they're fairly unlikely to want to start making people redundant. So in many cases, it may be more about ARRS money shifting to GPs by attrition as other people leave posts naturally over time, rather than PCNs making a sort of immediate effort to get rid of other staff and swap them for GPs right now.
We know the BMA wrote to Wes Streeting about this earlier this year and called for the government to allocate dedicated ring-fenced funding to practices so that they could employ these GPs. This has come up again over the last couple of weeks as part of some red lines that the BMA has given the government to avoid the profession re-entering formal dispute. What does the BMA want, and why have they raised the prospect of industrial dispute again?
We've talked previously about the fallout from the government's 10-year health plan, the fact that the BMA is really concerned about what the plan says about creating large-scale alternatives to the traditional GP model. It's two new types of contract that the government has outlined. The BMA is also extremely unhappy that the plan made no mention at all of negotiating a substantive new GMS contract for general practice, which the government has promised to do within the current parliament. And ultimately, the BMA feels that as things stand, the 10-year plan, the way the government wants to roll out neighbourhoods and the potential for hospital trusts taking on increased power is a big threat to general practice. I mean, there was an update to GPs from the BMA GP committee the other day, and that talked about a growing consensus across the profession that the current trajectory threatens the survival of the independent contractor model, and with it, NHS general practice and the trusted family doctor relationship our patients rely on and want to protect. So it's in that context that the BMA set out these red lines for government, and it said that if they aren't met, there's a chance of the profession going back into dispute with the government. Obviously this would be a return potentially to the kind of collective action that we saw the second half of last year and into the beginning of this year. And the BMA wants clarity on how much funding is available for next year's GP contract, how much is available for this major contract renegotiation that it wants to do and that the government's promised to work with the BMA on. And as you mentioned, it wants some guarantees too around ARRS money. And it says the ARRS budget should be moved into a practice-level reimbursement scheme. So the BMA is not happy about the fact that as things stand, that money sits at PCN level. So it's kind of divorced from individual practices, and it's concerned about the impact that has on the kind of job that is created for newly qualified GPs through this scheme. So it wants the ARRS budget moved into a practice-level reimbursement scheme. And it also wants an additional emergency scheme alongside that to tackle GP unemployment. It's also called for clarity from the government that it recognises GPs should play a key role, a leading role in the creation of neighbourhoods. So overall, it's fair to say, I think, that general practice is, again, at a bit of a crossroads, wants a bit of love from the government, which at the moment it doesn't feel like it's getting.
You really summed it up there, didn't you? I think it really is at a crossroads, isn't it? There's clearly lots of concern within the profession and within the BMA about what the 10-year plan means for the future of general practice. I mean, one of the things I found quite interesting is that we've had 2 interviews on the podcast in recent weeks with GPs who are very involved with at-scale GP organisations, but who are also GP partners. And when I was speaking to them, they don't necessarily see the 10-year plan as a threat to practices, but I think that might be because they are in areas with very established at-scale organisations that are working really effectively. I'd really recommend people listening to those interviews if they haven't already. They are really good insights from GPs who are already working in a lot of the ways the 10-year plan envisages, and they have a lot of insight about how this could all shape up in the coming years. Last week I was speaking to Dr. Andy Hilton from Sheffield, and then a few weeks ago there's an episode with Dr. Duncan Gooch, who is a partner in Derbyshire and chair of the NHS Confederation Primary Care Network, which represents at-scale primary care organisations. You know, it's interesting, alongside those red lines, around the same time the BMA put out guidance for practices and GP federations about taking part in the National Neighbourhood Health Implementation Programme. That's the scheme that's being run by the government and NHS England to roll out neighbourhood health. That guidance really very much spells out that there are risks and opportunities for general practice with all of that. One of those bits of guidance says that the 10-year plan could be the way to unlock further funding for general practice and potentially cement general practice's place as a strategic partner to lead the design of neighbourhood care models that would be really focused on continuity, prevention and personalised care. But then on the other hand, it also warns that if GPs aren't sufficiently involved in local plans or central to the way neighbourhood health develops, then money and commissioning powers could shift towards hospital. They called it a right drift rather than a left shift. And left unchecked, the BMA said the 10 years plan proposed structural and contractual changes could begin a move towards a salaried service or integrated provider model. So that's really quite a stark warning about where the future could be going. So no one can really tell at this point. The BMA clearly feels it could go either way. What the BMA is saying is that practices need to start working on this now, though, and really understand what's going on in their local area, even if they're not one of those 42 sites chosen for the government programme. It's basically recommending that practices, PCNs, LMCs and GP federations seek alignment on what they want, to map out the pros and cons of all of this, and perhaps most importantly, look at how and whether they can negotiate and lock in agreements that will safeguard the future of individual GP practices, however the local healthcare system in their area changes.
I think just coming back to something you said a minute ago, when you talked about the BMA talking about opportunities and the fact that the idea of shifting to neighbourhoods does create these huge opportunities, which general practice in some areas is already making the most of in a very significant way. But I think the fear from the BMA's point of view is that there's a lot of talk about really rapid changes. So talking about picking areas that could become integrated health organisations, and you could have a hospital foundation trust taking over the entire budget for the health system within very short order. You're talking about picking them by 2026 and then them going live by 2027. And the idea is that if you're a GP practice in an area that isn't already working in this way to some degree, then to go from a standing start and get yourself into a position where you can compete with hospitals or other big organisations that might want to lead these changes in short order is a really difficult challenge.
Yeah, definitely. I think the other thing that's worth mentioning about this is both of those GPs I spoke to, I mentioned earlier, both those interviews we've had on in recent weeks, they're both very clear. While they didn't see some of this stuff as necessarily a threat to the partnership model, they were both really clear that the core GP contract needs proper funding. You know, Dr. Duncan Gooch was basically talked about the fact that you can't have a thriving neighbourhood system without a thriving primary care system underneath it. So that means thriving GP practices, thriving optometrists, thriving dental practice. That investing in those building blocks is going to be so important to get this right. And Dr. Andy Hilton, he was talking about the fact that they work at scale, and they've been very successful in Sheffield about how they work at scale and how they deliver extra services and what they do. while they can do that, it hasn't solved a lot of the challenges and problems that practices have, because essentially the core GP contract is underfunded. So those issues around funding for general practice will need to be sorted out in the new GP contract. I think they will have to be sorted out if the government really wants neighbourhood health to be a success, because it's hard to see, how you could do this without it being built around general practice at its heart, with the patient list, with people who are embedded in their local communities and who understand their patient populations. I just can't see how hospitals will be able to have that insight and that knowledge that this programme of change is going to need. Before we go, we've just got time for our good news story, which is about a pioneering scheme in London that sees GPs and their teams prescribing fruit and vegetables to patients. The programme is the first UK trial of such an initiative, and it's been taking place at practice in Tower Hamlets in East London and practices in Lambeth in South London. Both boroughs have high levels of poverty, child poverty, income inequality and health inequality. It's been funded by the local authorities and the Alexandra Rose charity, which runs the programme. We spoke about this project on the podcast before in this good news slot, but last month new data was released from the scheme showing a 15% reduction in self-reported GP visits. These findings come from the scheme running in Tower Hamlets. That's part of Bromley by Bow Centre's wider social prescribing programme, and it sees health professionals and social prescribing link workers issue what's called Rose vouchers to people on low incomes with diet-related conditions. People have to collect the vouchers from the health centre, and they can then be used to buy fruit and veg at local markets. The latest findings show that 78 of participants met their 5-a-day target after 9 months, compared with 32% before the start of the project. And as I said, self-reported GP visits have reduced by 15%. Well, that's it for this week. Thanks for listening, and thank you to Nick. I'll be back next week when I'm speaking to Dr. Richard West, the chair of the Dispensing Doctors Association, about the challenges and issues facing dispensing practices and the value they bring to patients. So please do join me then. In the meantime, don't forget you can keep up to date with all the latest news and access other resources on our website at GPonline.com.